Very good morning to everyone, and I would like to thank AIOS and my seniors to give me the opportunity to speak on this topic. So the topic which I'm speaking on is 10 mistakes in dry eye, what not to do. So there's a misconception despite advances that dry therapy and disease, it's taken more casually because of our OPDs are busy and and this old misconception still exists. It is important to reevaluate these misconceptions because of high frequency and chronic nature of dry eye, and patient with dry eye often managed by comprehensive ophthalmologist in OPD rather than specialist. So the first misconception to a dry eye is that it is just a symptom and not a disease, and most of the time, even when I remember in my PGH sir said, we used to just label a person dry eye and give some lubricant and that's all. We never used to go in depth, as I remember my post-graduation, but this topic really needs more detailed evaluation and study. So dry disease, as the previous speaker has spoken, that it's a multifactorial disease occurring both in isolation or as part of a systemic disease. Dry eye disease has various etiology, right from autoimmune, hormone imbalance, systemic disease, hereditary disease, nerve damage, environmental habits like smoking, eye accessories like prolonged use of contact lens. So it's important to evaluate for underlying causes. The other cause which is very important is the systemic drugs which the patient takes for other conditions, which are often missed in our OPD. So this is a small group of, few group of drugs which can actually cause dry eye because of, by affecting tear production or its composition, right from antihistaminic, antidepressant, anticholinergics, decongestants, hormonal replacement therapy, oral contraceptives, acne medications like isotretinoin, blood pressure medication, and even pain reliefs. To consider dry eye disease as disease of cornea, lid and tears is another misconception because it affects the entire ocular surface apparatus as total. So it can affect right from cornea, conjunctiva, lacrimal gland, meibomian gland, eyelashes to nasolacrimal duct. So a detailed evaluation is needed in such cases, and it functionally linked to epithelial continuity, innervation of nerve, endocrine, vascular, and even immune system. Neural feedback loop, which is actually overlooked in most of the cases, which is a very important part of tear production, which regulate lubrication through corneal innervation by producing reflex or basal tear production by lacrimal gland. And that is the reason in post-herpetic eyes, patients have chronic dry eye because this loop is missing. So ocular surface disease should consider in treating ocular surface disease, the ocular surface system should be taken as a whole rather than treating isolating part. To consider, another misconception is to consider lack of tears as the cause of dry eye, which is also very much present with the patient, because when we tell them you have a dry eye, they think their tears are not getting produced. So dry eye disease has divided dry eye broadly into aqueous deficient and evaporative. Aqueous deficiency can be because of Sjogren syndrome, which can be primary, secondary, or non-Sjogren syndrome, which can be because of lacrimal deficiency like alacrimia or lacrimal gland obstruction, reflex block, or because of systemic drugs. Evaporative can be of various reasons, right from pneumonitis and going up to low blink rate, drug-induced vitamin A deficiency, topical drug preservatives which have toxic effects, or contact lens, use of prolonged contact lens use. Another misconception is to disregard ocular pain in absence of slit lamp sign. So sometimes we see patients where there's no inflammation, no sign of any other disease, but patient complains of a lot of discomfort, which is a challenging thing, especially after post-surgery, where so such kind of pain or discomfort is actually related to neuropathic pain, which occurs due to damage to the corneal nerves, peripheral corneal nerves. So dues to classification actually do take such patients into such cases into consideration where there are symptoms but not sign, which is neuropathic pain, or signs without symptoms, which is neurotrophic conditions. Such patients often complain of ocular pain, light sensitivity, dysesthesia, which is ocular discomfort without any symptom, or allodynia, which is discomfort in the presence of light. So pain generation can start at various nerve connection points right from the ocular surface to a higher order neurons. Unaddressed nerve dysfunction should be suspected in patients with persistent painful dry eye unresponsive to conservative or conventional therapy. There is a study which shows that autologous serum tears is very helpful in such conditions. I don't know, I have never used it, but this is something which I came across through a study that autologous human tears are really helpful to reduce neuropathic pain. So another point is to assume that dry eye patients without corneal damage do not suffer from visual disturbances. In fact, visual disturbances is one of the major symptoms which we see in our OPD, especially we should be careful while doing any refractive or even cataract surgery, because it can interfere with the vision by scattering of light, causing higher order abrasions, and even affecting the contrast sensitivity. The impact of dry eye disease on visual function can be evaluated by various questionnaires like Ocular Surface Disease Index, which is a very good questionnaire which includes 6 questions related to the visual disturbance, blur or poor vision, and visual function like driving, working on computer or watching TV. Apart from this, there are a lot of questionnaires available like speed questionnaire and dry eye screen questionnaire. So I think it's a good tool to quantify dry eye rather than treating a patient subjectively. And also to see how are the symptoms improving in the patient after therapy. So it actually standardizes the treatment. To underestimate the influence of dry eye on surgical outcome is another misconception, because especially after ocular surgery, they can be in a patient with persistent dry eye or undiagnosed, untreated ocular surface disease, can cause suboptimal postoperative visual acuity due to inaccuracy in preoperative calculations. Anti-glaucoma medications plays a big role, mainly because of the preservatives which are there in the anti-glaucoma drugs. And these anti-glaucoma drugs, as we all know, will be used by the patient for a long time. And as the number of drugs increases, the ocular discomfort and all the symptoms of dry eye will increase. So another misconception in OPD during our busy OPD is to avoid workup of dry eye. Most of the time we think that it's time consuming and requires high-tech equipments, expensive equipments, but it's not the case. This is a simple 3-step method to evaluate dry eye in our OPD, which will take less than 10 minutes. First thing is detailed patient history, which our associate or assistant can take with questionnaire as discussed previously, followed by just observing the patient, observing the blink rate, photophobia and other discomfort for which we don't even require a slit lamp. Then evaluating the surface by slit lamp, and then doing just simple tests like tear film breakup time, Shermer test, dye installation to check dye disappearance or damage to the ocular surface, cornea, conjunctiva, and just or doing esthesiometry or simple checking the corneal sensations in patients with dry eye. So another thing which we do is, or most of us do, is that just prescribe same kind of lubricant to all the dry eye patient. So although lubricants play a major role and they are the mainstay of dry eye treatment, and this slide shows the evolution of lubricants right from the first generation, which was saline based, to second generation, which were methyl cellulose or synthetic polymer based, and now the newer generation, which includes lipid component or osmoprotectants. Again, this is a slide which shows how to choose a tear substitute depending upon the symptoms and signs like MGD with inflammation, without inflammation, or epithelial defect. We can use a lubricant in isolation or in combination, right from osmoprotectant to gel-based tear substitutes for epithelial defect, and either combination of two in more severe condition. Now, advocating tear use on and off basis is another misconception. This is a study which shows there were 2 segments, one which was using a 4-time fixed regime, and the second which was using lubricant of on and off basis. And this study clearly shows that The group which followed a fixed regime provided better relief as compared to the on and off treatment. Another study in Japan which shows that almost 2/3 of the patients of dry eye discontinued their therapy on follow-ups of their own as compared to 1/10 of them who were using tear substitute as prescribed. So this shows that it's important to educate the patient, explain them about the nature of the disease, how the dry eye works, how the lubricant works for a better compliance. Last but not the least is underestimating inflammation. Just prescribing tear substitutes is not going to benefit the patient, as there's a vicious cycle of tear instability, tear hyperosmolality, which causes pro-inflammatory mediators release, which causes goblet cell damage, decrease in mucin production, which will lead to epithelial cell damage and further causing tear instability. So a short dose of tear, low dose, low potency topical steroids to break this cycle is important, and in severe and chronic dry eye it's important to give drugs like cyclosporin, which is a mainstay in chronic and severe dry eye, along with the lubricant. So key takeaways are reconsidering the most common misconception related to the disease in light of recent evidences can help physician in reaching a correct diagnosis of dry eye disease that is instrumental for the choice of proper treatment. Tailoring the treatment to the patient dry eye disease condition is the need of the hour strategy. Thank you.
Thank you, Ankit, for that very nice talk. In fact, there are so many misconceptions that we, and we try to generalize our treatments for dry eye, and many of these points you were able to highlight really well. So I think some of these revision points from time and again will really help everybody treat their dry eyes in a better, more scientific way, because there is a lot to it other than just, giving lubricants and just calling it as a dry eye, because this whole gamut of disease all around it.
Yes.
So thank you.